we have been utilizing this technique since 2008. This is not a new technique, but continues to evolve as we try and train more people to at least consider the option for patients and even consider the options of acquiring this skill set in order to utilize this in their patient population. This is a full seminar for, as I said, for about 45 minutes. The key to success is with anything in complex solid organ oncology, whether it be rectal cancer, esophageal, hepatocellular, cholangio, and pancreatic, obviously, is around optimal patient selection. Understanding the optimal imaging that needs to occur, understanding which margins potentially will either be at risk if you think this is resectable, or what margins are clearly at risk if you think this is unresectable, and where an In-Situ IRE can be utilized. Understanding that induction-based systemic chemotherapy is a backbone to the success of utilizing IRE to improve both the progression-free survival and the overall survival in these management. Go over our recent publication that came out last fall, outlining these pure subsets of stage 3, which clearly have significant effects in regards to resectability, and then the sequencing of chemotherapy with IRE, and then where radiation therapy plays a role. I'll touch briefly on the use of an In-Situ technique, optimizing probe location, optimizing placement, and then also discuss the use of margin accentuation in the patients who are technically resectable but have locally advanced disease. This is a first part of a multi-part seminar outlining these types of effects. Additional future seminars will involve the intraoperative and postoperative complications that occur in patients who have undergone IRE in an In-Situ technique for locally advanced pancreatic cancer, understanding the perioperative and postoperative imaging and the response assessment that occurs with IRE and locally advanced pancreatic cancer, and then future combination therapies. Obviously, immunotherapies, the use of immunomodulation, and the potential benefits that we're starting to see in our initial research utilizing this. It goes without saying that the critical features of staging and adequately optimizing patients with pancreatic cancer is imaging. Pancreatic adenocarcinoma is one of the few malignancies that we treat to which all of the treatment decision is based on staging. It, however, is not a solid organ that requires certain types of quality imaging. If we compare this to rectal cancer, which we also obviously utilize imaging for staging, it's unheard of that patients would start chemo and chemoradiation therapy without having an endoscopic ultrasound of the rectum and an MRI of the rectum to make sure that they appropriately stage patients. Pancreatic cancer, unfortunately, is not that standardized. There are multiple patients who are staged with poor quality imaging, MRIs with significant amount of respiratory variation, thick cut CT scans. At a minimum, it is required that a triple phase CT scan be performed in patients prior to initiating any treatment. I get a lot of pushback by sometimes patients who will come in and say, well, they had a diagnostic CT, and people will say insurance won't pay for it. Unfortunately, I think that's untrue. If you push and you clearly need a higher quality imaging with thinner cuts at 1.25, with power injection that allows you to have all of these types of dynamic phases to allow you to have precise staging, that is of utmost importance. There are numerous patients that may be staged, these are presumed stage 4 because of questionable lesions in the liver, or presumed stage 3 that will then get higher quality imaging and are actually a 2A or a 2B. Given that there are significant treatment variations between 2A, 2B, 3, and 4, it behooves us to make sure that we get that type of high quality imaging. Additionally to that is three-dimensional reconstruction. And it's important that all surgeons have this type of 3D reconstruction evaluation, which allows you to truly assess where your risk of margin assessment is. This is a 3D reconstruction outlining in red where a R1 resection will be of greatest risk, yellow in which the margin will be between 1 and 5 millimeters in distance, and then green, which is a margin that is greater than 5 millimeters. Having this type of reconstruction, which can be done on many different types of imaging modalities, this is one type of fee-for-service modality, MEBIS, to which you send the images to them. They then reconstruct your high-quality imaging and then allow you to have this type of sequential access for both rotational assessment as well as margin assessment, so that you can really evaluate if that patient is going to be a high-risk stage 2B in regards to its margin assessment, or more importantly, intraoperatively, they will be a stage 3. And that having that type of information prior to surgery is of critical utmost importance. We clearly must make the non-therapeutic laparotomy occurring in less than 2% of all patients who are operated on. Having patients come to the operating room, have a midline incision, and have a non-therapeutic laparotomy, meaning that nothing is resected, nothing is done, is ultimately should be a never event. And utilizing high-quality imaging with this type of margin risk assessment can allow you to achieve that. I cannot tell you the last time that I had a non-therapeutic laparotomy based on the adequate risk assessment that occurs both with diagnostic laparoscopy at the beginning of the operation, as well as with this type of risk assessment to allow you to assess that. We've recently published on this in 2019, demonstrating that a 3D reconstruction is critical, especially in patients who with pancreatic adenocarcinoma, and then especially in physicians who are just finishing their training, PGY5 residents, as well as recent graduated fellows, as well as physicians who are in their first 5 years of practice, is where they can have the greatest variability in regards to their interpretation about resectability, margin assessment, and the ability to have a true R0 type of resection planned preoperatively and then achieved intraoperatively. Utilizing some degree of 3D reconstruction is critical for patients' satisfaction and quality. Now, the other part of this is also understanding the definitions of resectability and what makes a patient resectable or unresectable. This is in the United States, a fairly well-established and agreed upon that you are reaching a stage 3 or unresectability if you have arterial involvement greater than 180 degrees of either the SMA or the celiac axis. Having complete occlusion of the SMV with collateral vessels is a universal unresectability. There is some variation outside of the United States. The Dutch definition is slightly different than this. The Asian definition is slightly different than this. So again, I think it's critical where you practice to understand where those definitions lie. In the United States, this is universally agreed upon between stage 2B, which is borderline, and stage 3, which we call locally advanced or unresectable. Now, the unresectability is starting to go away, and I'll talk to you about that. There are patients who have a locally advanced tumor that actually are technically resectable. Understanding the degree of vascular involvement, regardless of the radiology interpretation, is critical to the quality of managing patients with pancreatic cancer. There are clear radiographic differences of abutment, encasement, and then involvement and true invasion. Assessing that, understanding that preoperatively to make sure that these are not intraoperative findings is critical, again, to the quality of the intraoperative resection. Now, if we take stage 3 or locally advanced patients, it is my utmost biased opinion, and we have data that truly supports that, neoadjuvant chemotherapy must play a role in all patients with either stage 2B or stage 3 pancreatic adenocarcinoma. We must understand the biology of the disease. I do not sit here and say that all stage 3 patients are true locally advanced. They have no micrometastatic disease and are not at risk of micrometastatic disease. That's a naive thought, and I can't believe that most people would believe that. There is a subset of stage 3s that do have that more favorable biology. It is our job as treating oncologists to identify those patients, which is where neoadjuvant chemotherapy plays a role. There are only 2 therapies that should be initiated: gemcitabine and Abraxane as a first line, or modified FOLFIRINOX. Now, again, I get a lot of pushback from some treating physicians who would say, oh, they're too frail to get modified FOLFIRINOX or too frail to get Gem or Abraxane. Well, then usually what I tell them is you need to fix that frailty. It's usually a nutritional frailty. It's usually a physical frailty in regards to rehab. It's usually some form of other type of medical problem that needs to be optimized. If you improve upon their frailty, I have found majority of patients, even if you delay them 2, 3, 4 weeks to modify that frailty, then they can get on a more active treatment. Putting patients on locally advanced pancreatic cancer on single agent Xeloda or even single agent Gemzar, it really is equivalent to a placebo effect. And I'm not sure we're really gaining benefit. Now, if that is truly understood by the patient and truly understood by the patient's family, that they're trying a suboptimal palliative chemotherapy simply to see what can happen, that makes perfect sense. But if you can't put a single agent therapy and call it neoadjuvant, because you're really not going to get any type of response from that neoadjuvant therapy of at least 4 to 5 months of duration from the time of diagnosis, it's reassessing their response rate using RECIST 1.1. It's also assessing their response rates using CT PET scan, which is now an NCCN guideline throughout the United States. Patients with pancreatic adenocarcinoma can get CT PET scans for their staging. Monthly CA19-9 is critical, and then we are starting to see some initial reports, especially from our university and others, about the use of radiomics for predicting underlying biology. Now, we recently published this paper in the Frontiers of Oncology in January of this year, specifically around this topic, optimizing patient selection. It was close to 200 patients. Median overall survival from diagnosis was 25.5 months, in line with multiple other of our presentations and publications over the last 12 years. The key things that we found to be a predictor of overall survival was the lack of prior radiation therapy before IRE. There was actually a negative predictive value for the use of radiation prior to IRE than when we compared the use of radiation after IRE. I'll show you what those survival curves are. In addition to that, we also found a significant survival advantage in patients who were initiated with modified FOLFIRINOX and had that type of response rates based on their CA19-9 or had a chemo switch. So they may have had an initial response with modified FOLFIRINOX, they plateaued, and then were switched to Gem/Abraxane. We also saw significant survival advantage of that. A CA19-9 level at this time is a fairly reasonable surrogate marker of serologic response. Now, I understand there are close to 30% of patients who were not CA19-9 antigen expressors, and that obviously is something where a CT PET scan can be helpful for assessing that response. That should be part of that type of treatment algorithm. These overall survival curves sort of demonstrate that summary of what I presented from that manuscript in January. Neoadjuvant or induction-based chemotherapy for at least 5 months from the time of diagnosis clearly portend to an improvement in overall survival, and that's based on patient selection. We clearly were able to sub-select out the patients who had stage 4 disease. Patients with stage 4 disease should have no local therapy, shouldn't have IRE, shouldn't have radiation, and clearly should not have surgical resection. I think everyone agrees upon that. Prior radiation therapy was probably the single greatest thing that we saw. Here in blue are patients who did not have radiation therapy prior to IRE. And in red are patients who had radiation therapy, either high-dose SBRT or attempted ablative types of therapy using IMRT, clearly demonstrating a significant survival disadvantage with the use of pre-IRE radiation therapy. The use of modified FOLFIRINOX and gemabraxane, that type of chemo switch response, clearly portended to a much greater overall survival than just sticking with gemcitabine alone or modified FOLFIRINOX alone if there was a lack of response by either stabilization of the tumor diameter, uncommon, the most common being a drop in the CA19-9 level, or if not a CA19-9 expressor, then a response on CT PET scan. Driving the CA19-9 level from an abnormal level to a normal level was a significant surrogate of improved overall survival prior to IRE use. So again, demonstrating that there is a serologic surrogate marker that we can use in the management of these patients. Lastly is the patients who underwent an In-Situ, and for education, In-Situ ablation is a patient who has a disease in place. We therapeutically electroporate that tumor, and it is not removed. Margin accentuations are patients who have maybe earlier stage 3, and we still proceed with resection with margin accentuation. And interestingly enough, the patients who had an In-Situ ablation with therapeutic or curative approach actually had an improved overall survival versus the same stage 3 patients who had resection with margin accentuation. Again, early data, provocative data, but it is something to consider out as we start to, again, evaluate for patient selection. I would be remiss if I didn't at least emphasize the germline requirements and high recommendations of getting adequate amount of tissue at the time of diagnosis or at the time of IRE ablation for doing germline testing for patients. The percentage of patients who have actionable disease, I don't disagree, is very small. However, in that subset, if you're in that 5.5%, there are potential targeted therapies where patients do respond significantly better. Now, if we break down the stage 3s, because ultimately stage 3 locally advanced disease involves both SMA involvement, celiac involvement, or SMV portal vein involvement, one of them or a combination of all 3. So we recently published last year subdividing the staging. And what we did was specifically around both technical resectability as well as patients who were never going to be technically resectable. So again, patient selection would allow you to optimize who potentially could be resectable with margin accentuation and who would be acceptable for a pure In-Situ electroporation. Not all stage 3 disease is created equal. There's clearly different anatomic involvement, and it is critical to make sure that high quality imaging allows you to identify that. And that's what we did, is we broke the stage 3s down into 3 subsets. Stage 3A is probably the simplest, and that's with a celiac axis involvement alone with reconstructable venous involvement isolated. These patients we find are a subset with a pancreatic neck tumor alone. They do not present jaundice, and they do have potentially the greatest incidence of technical resectability. Stage 3B1 is the subset of that, and that's the uncinate process lesion that just involves the SMA with or without a reconstructible venous involvement. This again is usually a patient who presents with a small tumor, 2-3 centimeters in maximum axial diameter, with circumferential involvement of the SMA alone, does not present jaundice, and again, does have some surgical resectability options. Stage 3B2 is a combination of arterial involvement, and that's both a celiac axis and SMA. Again, more commonly a pancreatic body neck tumor that then grows along that vascular arcade, or is common to involve both celiac and SMA, when the ostium or the takeoff of the aorta is fairly close to each other. A stage 3B2, again, outlining both celiac and SMA involvement on the sagittal image here. Stage 3C1 is all about unreconstructable SMV portal venous thrombosis with collateral vessels. Everyone agrees that these are technically unresectable because of the inability to reconstruct the venous inflow. And so stage 3C are patients who present with just isolated SMV thrombosis alone with collateral vessels. Stage 3C2 is, again, unreconstructable venous obstruction with celiac axis alone. 3C3 is, again, unreconstructable venous involvement with SMA involvement. And a 3C4 is all three: unreconstructable portal venous SMV thrombosis with collateralization, SMA circumferential involvement of or at least greater than 180 degrees, and then greater than 180 degrees of the celiac axis. We have found that this subset is actually quite helpful and is quite important solely because of the resectability options. Stage 3A, which is celiac alone, approximately 40 to 45% of those patients actually are technically resectable with a distal pancreatectomy with a celiac axis resection. Stage 3B1, we have also identified in our 12 years of looking at this, do have a technically resectability of about 20 to 30%. And that's based on intraoperatively, the SMA involvement is not as extensive as we've seen on a preoperative CT scan. Volume averaging with CT does occur. Awareness of that and assessment of that intraoperatively can have patients who actually are resectable. 3B2s, which is involvement of celiac and SMA, very low resectability. And then obviously the stage 3Cs, there is 0% of those that are resectable because of the inability to reconstruct the venous involvement. Why that's important is that these two stages, 3B2s and all the 3Cs, preoperatively, I know they're all going to be In-Situ IREs. They require minimal amount of dissection. There really should be no dissection intraoperatively prior to IRE administration, and that the only evaluation that occurs is a diagnostic laparoscopy prior to exploratory laparotomy to make sure that you're not missing stage 4 disease. Stage 3As and 3B1s do require some degree of dissection to assess their resectability. And then that allows you to then decide, should they be a resection with margin accentuation, or can they be an in-situ ablation because of that significant amount of degree of involvement? This is critical for preoperative patient selection and to optimize that type of operation. Now, this is a busy slide, and I don't really apologize for it, only because the management of patients with locally advanced pancreatic cancer and stage 2B is truly multidisciplinary. You as the surgeon and the treating medical oncologist and the other supporting physicians ought to be seeing these patients back every 2 months to reassess both their surgical fitness, their response to therapy, as well as their underlying decision-making in regards to what treatment options are available to them. That would involve initiating modified FOLFIRINOX for 2 months or getting 6 doses. Most people would define that as 3 cycles of gemcitabine and Abraxane. If patients are truly responding, and they are responding based on RECIST 1.1, having stable disease or partial response, a reduction in their CA19-9 level, and a reduction in their CT PET avidity, then continuing modified FOLFIRINOX for another 2 months is of a key importance. In addition to that response, patients need to be making sure that they're tolerating an adequate amount of therapy. If you're seeing dose delays and the medical oncologist is having to dose reduce below 85%, that's a lack of tolerance. And so those patients then would not be tolerating their therapy well, and they should be switched over to gemcitabine and Abraxane so that you can obtain that type of optimal response as outlined by RECIST 1.1, drop in a CA19-9, and a CT PET. We commonly like to have 4 months of induction-based systemic chemotherapy with 8 cycles of modified FOLFIRINOX and approximately 12 total doses of gemcitabine and Abraxane based on your dosing schedule. If you're doing 3 weeks on, 1 week off, if you're doing 2 weeks on and 1 week off, or if you're doing every other week dosing, that can allow you to truly assess, do you have a stage 3 disease still based on that response? And then based on that stage 3C, subclassifying them as either 3A, 3B1, 3B2, or 3BC, which then allows you to preoperatively decide what surgical therapy is optimized for them. Resection with IRE or IRE alone. Following that, 4 to 6 weeks later, we then resume their systemic chemotherapy, because at the time of diagnosis, the goal is to get a total of 12 cycles of modified FOLFIRINOX or 18 total doses of gemcitabine and Abraxane. Pardon me. 3 months after starting that, we then restage them, and if lymph node sampling does identify positive lymph nodes, then consolidating those lymph nodes with Xeloda and IMRT radiation therapy is part of our standard of care. Radiation does play a significant role in the management of locally advanced pancreatic cancer. I just believe it plays a greater role after IRE, allowing you to target that lymph node disease, because that's where we see the greatest response from radiation therapy. When we do an In-Situ IRE, we do not treat the lymph nodes. So this is where that collaborative multidisciplinary approach is critical. Now, if a patient is referred or comes with prior radiation therapy, is IRE an option? Well, first and foremost, IRE is not a salvage therapy. If patients are sent to you after second line, third line systemic chemotherapy, IRE is not going to help those patients, and they're never going to be a candidate. If they come to you after radiation therapy and they have received high dose radiation therapy, which is defined as greater than 5,400 centigrade, then in most instances, if they are above that, I will not recommend IRE on them, solely because of the significant amount of effect that the irradiated arteries and vasculature has occurred. There is clearly medial thinning and adventitial fibrosis. We found that when we attempted to treat those patients with IRE, their ability to recover from it is significantly prolonged. Their quality of life is significantly decreased because of the underlying ileus and ascites and all of the vasculitis that occurred because of the high-dose radiation therapy, which is then exacerbated with the IRE. So in most instances, if they've received greater than 5,500 approximate centigrade, I may not offer them IRE, or if I do, then it would be at least 6 to even 9 months after the last dose of radiation. If they've had standard radiation of less than 5,400, then I wait at least 3 months before I offer IRE. You do not want to hit the patient twice, meaning finish radiation and then immediately do IRE on them. You can get that type of side effects. If they've had high-dose SBRT, then I wait at least 6 months, again, because of that radiation effects. And then you really need to assess where the radiation fiducials were placed, because those are obviously metal, and I'll touch base as to why getting an adequate IRE with implanted metal is not possible. If we now look at the optimal IRE technique, you have to understand the 5 steps of treating these patients. Patient selection, which is obviously the main focus of this seminar today. Treatment planning, which I've touched on, CT PETs, tumor markers. I'm going to predominantly focus the next couple of slides on IRE targeting and dose delivery. The response assessment, again, is another seminar talk, but it is critical that all 5 of these are managed in a multidisciplinary, team-based, collaborative approach. Optimal patient selection, again, I've gone over multiple of these, but just to emphasize, biology of the disease, clearly the fitness of the patient, making sure that the size of the tumor is less than 4 centimeters in size in the axial phase, and you must have removable metal stents. Patients that are sent with bare metal biliary stents commonly are not candidates for IRE, and patients that are sent with multiple gold fiducials after SPRT are commonly not good candidates for IRE because of energy deflection as well as heat. Neoadjuvant approach I've touched upon. And then the other thing to also evaluate is to evaluate and decide preoperatively what additional concurrent procedures are essential. It's not uncommon that most patients who have biliary stenting and have a stage pancreatic head tumor, we will do a bile duct resection, removal of the stent, and do an hepatic jejunectomy at the time of operation. We have found that leads to better long-term biliary patency. It also helps the patient's quality of life because they're not coming back every 8 to 12 weeks and getting a stent exchange during their overall survival. Given that our median overall survival is now greater than 26, 27 months, you can see that's multiple stent exchanges and multiple ERCPs that potentially could be avoided with a simple hepatocogegenostomy. The need for a gastrogegenostomy, again, is predominantly related to duodenal invasion. If you see that duodenal stricture, you see that duodenal invasion, then doing a gastrogegenostomy is going to be helpful. IRE induces edema. That type of edema can make a stricture worse. So consideration of a gastrogegenostomy is helpful. Pyloric exclusion is also a unique subset that you should consider if there is truly transserosal and mucosal invasion of either ampulla or duodenum. Patients who present with those types of tumors are at much greater risk of having an ulcer 3 to 4 weeks post-procedure, which can lead to an upper GI bleed through reperfusion of the gastroduodenal artery. Let me walk you through that. If a patient has a cancer going through the mucosa of the duodenum or the ampulla, you perform a therapeutic curative IRE, you will kill that cancer. That cancer will die. If you allow bile or acid to continue to roll through the duodenum, that area of transmural invasion will ultimately turn into an ulcer. 3 to 4 weeks after IRE, when you get that normal reperfusion effect, that ulcer will then turn into a bleed because of the gastroduodenal artery or because of reperfusion from the SMA, and then you're having patients presenting with significant upper GI bleeds. Thus, preoperatively, if you know there is any type of mucosal invasion, then I recommend doing an hepatocogegenostomy, a gastrogegenostomy, and then a pyloric exclusion with a non-cutting TA stapler so that you allow that area to both die, the cancer die, and more importantly, to prevent that type of ulcer rebleed. J-tube and the use of J-tubes are something that we do use because it allows us to discharge patients quicker, and they're not as much of a focus on their postoperative nutrition because we can control those values. Probe selection. How do you determine what size and what number of probes you utilize? It's all about tumor size. If you're dealing with a small stage 3B1, say SMA type tumor around the onset process, and it's maybe a 1.5 to 2 centimeter tumor, then you can get away with 2 needles. Needle here, and it will give you this type of electroporation type of therapeutic effect. If you're dealing with a larger size tumor, then utilizing a 3. The most common number of probes are utilized for pancreatic head and neck tumors that I've treated in the last 12 years with over 350 patients that we've treated is going to be a 4-probe technique. That's most common. Patients that require a 5-probe technique or 3 separate triangles are commonly that pancreatic body neck tumor. We find that axial extent is the widest in the axial, and so needing 5 probes to truly cover and encompass that entire tumor is critical. Now, again, what we try and do is we try and make sure these needles are placed bracketing the tumor. You can't always do that, especially with larger tumors. And you can't always do that, especially with the anterior pancreatic capsule. Sometimes these needles do have to go through that anterior portion of the tumor so that you have that type of electrical potential that occurs across needles. Now, the things to remember, this is only possible safely intraoperatively with the use of high-quality intraoperative ultrasound. Every needle needs to be placed with the exact precision, given the fact that spacing, it needs to be within 2 to 3 millimeters, and given the fact that we need to make sure that the needles do not damage any type of surrounding structures. So the number one question you have to ask yourself, are you an expert in intraoperative needle placement and multiple needles, that is? If you are not, then that is a true sign for collaboration. Interventional radiologist, someone who is an expert in needle driving and needle placement that you can collaborate with the first 5 to 7 cases that you do to get over your learning curve to make sure that the needle placement is not done with a lot of damage. The other is the degree of ultrasound you have. You must have a 2018 or newer ultrasound machine that has either high definition or high frame rate speed. If you are using an ultrasound machine that is older than that, you are putting the patient at great risk of having intraoperative damage with needle placement alone, and that's not even with the energy delivery. It is critical that you have this type of high definition in order to make sure that your needle placement is done atraumatically. I commonly use a biplane probe. It allows me to image simultaneously in an axial and sagittal plane. I've been using this probe now for over 12 years. I will not do an In-Situ IRE unless I have a biplane probe. It provides safety, it provides accuracy, and it provides efficacy, which is of critical utmost importance when placing needles in these patients. Here's an example of a stage 3C patient with venous involvement that I thought was unreconstructable, had SMA involvement in celiac axis. And this video kind of walks you through. All needles are placed in a cranial to caudal fashion. Those patients who have these kind of mid-body neck tumors that are extending slightly down halfway through the involvement of the pancreas, will do minimal dissection. I do not get into the lesser sac. I commonly recommend that you don't do that. I will image ultrasound transgastric, imaging through the stomach, which is not a problem. There's not a lot of air in the stomach. It actually is a great way for crystal apposition. I then identify where I need my foundation needle to go. And my foundation needle is this number 1. And that is to the left of the SMA at about 3 to 4 o'clock, clearly missing the first jejunal branch. We then use spacers, which you will then see, to then build this type of 5 needle array or 3 triangle array. Once I'm able to place that foundation needle, the number 1 needle, and it's in good position, then I use spacers at 2 centimeter spacing to then build from a posterior clockwise fashion, as you can see here, so that none of the needles are causing any type of obstruction of your ultrasound, doing your posterior needles first, and then building your anterior needles from that. Again, as you all most know, there's not a lot of tissue above the pancreatic capsule, and that's why we have to put the needles into the tumor. The energy occurs through just 2 needles at once. And so this video will then walk you through the 2 needles that are where energy is occurring. From that, because your probe exposure is only 1 to 1.5 centimeters maximum, it does require a pullback so that you can then encompass and get both a superior margin and an inferior margin along that tissue, whether that be in normal pancreas or whether that be in transverse mesocolon. It is critical to the efficacy that you have to do that type of pullback in order to encompass and get complete electroporation of the tumor. Here is another, again, schematic of outlining this, all right? All needles, again, are placed in a caudal to cranial fashion, bracketing the tumor and the vital structures. Once you establish that type of electroporation, then you are pulling back the length of the needle exposed. So you're either using a 1 centimeter probe exposure or 1.5 centimeter probe exposure. You pull that back and then are doing another sequential electroporation. I have found this is the safest and most efficacious way of placing the needles. You place them parallel to the vital structure. Because of that, that leads to atraumatic needle placement as well as efficacy of the electroporation, so that you're able to get those type of sequential margins across those vascular structures. Right. Now, the keys to margin accentuation is the same. Ultimately, if you are doing a resection for a locally advanced stage 3A or for a 2B, I think the key part about this is that you need to do your margin accentuation early. You must have limited dissection. It is not possible for you to do a complete resection and then try and place needles. There is no tissue there. You won't be able to place needles effectively. So you have to do your margin accentuation and your needle placement sometimes in the first third of your dissection. What are some of my intraoperative factors that lead me to take what I believe to be is maybe a technically resectable stage 3 or 2B and move it into a unresectable stage 3 that requires an In-Situ IRE? There are 3 major factors. One is extensive vein involvement, greater than 3 centimeters, a combined vein and celiac involvement. I don't recommend doing a major venous resection and a major arterial resection. And then the third is an R2 margin on the left side of the SMA. If I'm dealing with a stage 3B1 SMA involvement, I commonly will lift the transverse mesocolon up, dissect to the left of the SMA, and take a frozen section. If that frozen section is positive, then this patient is a In-Situ IRE. I'm not going to resect a patient who has 360-degree malignancy around the SMA. There's no benefit for doing that. Once margin accentuation is confirmed, as I said, you must do it early. Examples of margin accentuations: you can accentuate the SMA, which is a 2-needle approach. You can margin accentuate the SMV, again, in a 2 or 4-needle approach. Or you sometimes may have to accentuate the pancreatic neck if you are doing a subtotal left pancreatectomy and you want to accentuate that neck margin here. And again, is a 2-needle approach in this location. It's not uncommon that you will need to do 1 or 2 pullbacks to get that 3-centimeter margin and accentuation of that. Now, what are the quality metrics in energy delivery? Again, not trying to treat a tumor greater than 4 centimeters in size. It's just not technically feasible. And the electroporation success is less than 10% when you try and go above 4 centimeters. You must have a high quality ultrasound. You must cover the entire tumor with needles. We don't try and do any kind of overlapping ablations. We don't try and do 2 needles and then 2 needles. You will not get efficacy in that aspect. Optimal probe length for pancreas is 1 to 1.5 centimeters. In occasionally other types of pancreatic malignancies, you can get away with 2. You must deliver a minimum of 100 pulses across each probe pair. I usually average 160 pulses across each probe pair in order to get efficacy. And then obviously considering concomitant procedures, which I've touched on before. The spacing of the probes is the single greatest efficacious quality metric that you must focus on. The optimal spacing is 1.5 to 2 centimeters. If you go too narrow, you will not get an efficacious ablation. Similarly, if you go too wide, you again will not get an electroporation and you will get a non-therapeutic approach. The sweet spot, as outlined here, is really 1.5 to 2.2 centimeters at most. If you are at 2.2 or 2.3 centimeters, then commonly I am delivering at least 100 pulses across those probe pairs in order to get that type of efficacy. The impact of metal. Again, I will finish just with the technique aspect. We know that there is significant deflection of metal when metal is within the probe pairs or close to the probe pairs. This mathematical modeling, as well as gel modeling, clearly demonstrates when you have no metal, you will obviously achieve an electrical potential, as outlined here in red, of at least 750 volts for efficacy. You do not get that when you have metal either in an in plane or in an orthogonal plane. You similar don't get that if you have a titanium clip in between the needles or a gold fiducial. So any type of metal is going to lead to that type of deflection. Our data has also demonstrated that during that deflection, this metal will actually heat up and will cross into a thermal threshold. So there are clearly patients who cannot be treated because of pre-IRE management that of no fault of yours, but I would not recommend trying to treat those patients. Overall survival has clearly been demonstrated. We now have 4 major publications that have identified median overall survival at a minimum of 24.9 months, which to improvement to almost 30.2 months, with our most recent publication confirming 26 months. There is no systemic chemotherapy out there that has been close to that, regardless of some of the meta-analysis that have come out that have muddied that type of interpretation. If you do high-quality patient selection, high-quality IRE energy delivery, achieving overall survivals of 30 months or more is clearly possible. In summary, again, significant overall survival can be achieved with adequate induction neoadjuvant chemotherapy, adequate and high-quality IRE, and then the use of radiation therapy in patients with lymph node disease or high-risk disease. IRE is not a salvage therapy. As I mentioned before, you should not use IRE in third-line therapy after systemic chemo, and should not use it in patients who have had high-dose radiation therapy greater than 54 to 5,500 Sag. You must optimize the technique. It is a technically demanding procedure, but that is okay. There's nothing wrong with that. More importantly, the keys to sustainability are obviously establishing these types of techniques and maintaining that type of quality. Thank you all for your time and attention.